Hello, it's Experts Talk program on Qazaq TV. Chief Virologist of Georgia and Director of the Tbilisi Center for Infectious Diseases, AIDS and Clinical Immunology, Tengiz Tsertsvadze.
Gamarjoba, Tengiz Nikolayevich.
Gamarjoba.
Tengiz Nikolayevich, you are the head of the clinical control group which coordinates all clinics in Georgia where coronavirus infected are treated. Your experience is priceless. We have made one major amendment to the WHO recommendations. At the beginning, the WHO recommendations stated that only those with a temperature of 38 or higher are considered suspicious cases. We very quickly became convinced that such a fever, such a high temperature, is not necessary at all, since 80% of infected people do not have such an increase in temperature and, by the way, this turned out to be a very serious problem for many European countries. In European countries, only those who had 38 or higher were controlled. But it turned out that 80% did not fall into this category. They disappeared into society and they began to spread the infection, and we chose this temperature criterion. If any person had signs of an acute respiratory infection, cough, sore throat or any other, and of course the temperature, but it was not a mandatory criterion. They immediately had to call the ambulance and dial the number. They took this patient to the family doctor, but not to all family doctors. Many family doctors were not prepared to manage this new disease. About 40 primary healthcare centers, the so-called family doctor centers, were specially selected. They were specially trained, and all those who called the ambulance were transferred to these 40 family doctor centers. They consulted patients and considered both symptoms and especially anamnesis. If these people had a history of traveling to high-risk foreign countries, or had contact with suspected patients or received foreign gas, these family doctors would in any case refer the potentially infected patients to so-called fever centers. Several dozen so-called fever centers were established in Georgia, where these patients with suspected COVID applied. They were all tested and the results were within 12 hours maximum. This was of very serious importance, and within 12 hours, the patient already knew whether he was infected with COVID or not. If he was not infected with COVID, he continued to be treated by a family doctor or doctors of another profile. If he was infected, then he was sent to the so-called COVID clinics. There are only 11 of them in Georgia, and they were all hospitalized. And the next, I consider it very important, this is a very insidious disease. Experts already know, and the public, the population will now learn that this is a completely specific disease, which is in no way similar to other respiratory infections, including influenza, to which it was very often compared at first. This is not only viral pneumonia, it is actually a multi-organ disease. With COVID, almost all organs and systems are affected. And this disease has a various insidious property. It can indeed be asymptomatic or low symptom, easy, but have a tendency to quickly weigh down, even starting seemingly asymptomatic in some cases. Not often, there is a rapid weighing. We have developed a very effective system. First, the patient is supervised not only by an infectious diseases specialist and resuscitator, but by a multi-profile, multidisciplinary group of doctors, which includes infectious diseases specialist, resuscitator, cardiologist, pulmonologist, neurologist, endocrinologist, nephrologist, and others. Because the vast majority of COVID patients, especially in critical and severe conditions, and the total number of these severe and critical patients is somewhere between 15 to 20% of the total number of patients. They usually have damage to various organs and systems, and this multidisciplinary group is better able to manage this. For example, we have very frequent disorders of the blood clotting system and thromboembolic complications called thromboembolism, which we monitor very effectively using anticoagulants from the very beginning. Next, all patients undergo a CT scan because on a regular X-ray examination, half of the patients do not have pneumonia, atypical pneumonia. The symptom of frosted glass is not visible on a regular X-ray, so all patients were subjected to computer tomography. And always in audiographic mode. It is very important, because when you just do a CT scan, you can miss out on thromboembolic complications, which are often the cause of death. If you do it in audiographic mode, you are much more likely to fix these thromboembolic complications and conduct conservative therapy or sometimes even surgery. We have developed the principles of antibiotic therapy very well. It is not very easy to distinguish whether it is only a viral pneumonia or a disease or a secondary bacterial infection. Bacterial pneumonia or sepsis or septic shock has already been connected. We have a well-developed system for differentiating thrombovirus and bacterial infections. This allows us to avoid the use of antibiotics when they should not be used, and on the other hand, to start in a timely manner when they should be used. Another very important role in the management of patients in Georgia is played by the so-called cytokine storm or cytokine release syndrome. This is one of the leading pathogenetic links to this disease. For non-specialists, it is difficult. Therefore, I will not speak in a professional language, but for specialists, it is a well-known cytokine storm syndrome. When in response to a viral or bacterial infection or to some stress condition, an excessive number of cytokines, primarily the main cytokine B-cell stimulatory factor 2, which is the conductor of this cytokine system, and an increase, sometimes a catastrophically high increase in B-cell stimulatory factor 2 is followed by an increase in all other cytokines. This release of excess cytokines is first used to protect the body. It is a protective reaction of the body against infection, but later, when released in large quantities, they cease to play a protective role and, on the contrary, destroy their own body and often cause the death of these patients. Therefore, it is necessary to respond very clearly to the development of this cytokine storm. If this is a moderate release, do not interfere, because this is a protective reaction. If there is an excess, there are absolutely accurate parameters. And it is very important. I advise everyone, because this is not implemented everywhere. For example, in Georgia, it was initially done only in our center, and all COVID clinics sent and are now sending blood for testing to us. The definition of B-cell stimulatory factor 2 is a key laboratory test for the correct management of COVID-19 infection. The definition of B-cell stimulatory factor 2. And if extremely high numbers of B-cell stimulatory factor 2 are observed, then intensive measures must be taken to treat the cytokine storm. There are several directions here. First, medications are used that block the receptors for this B-cell stimulatory factor 2. And in fact, B-cell stimulatory factor 2 circulates in large quantities, but the receptors for it are mute, the receptors do not perceive it. So, the safest method is extracorporeal blood purification from these cytokines. This is basically a safe method. There are special cartridges, sorbents, that is, absorb these cytokines. True, they are difficult to get, they are expensive, but we bought them. One cartridge costs about 800 euros. They are produced by a number of American companies, and there is a grand demand for these cartridges on the world market. This cartridge is inserted into a regular hemodialysis machine, the one that treats patients with kidney failure, and the blood passes through this cartridge and is filtered. The excess of these cytokines remains in this cartridge. As a result, the patient's condition improves significantly quickly, and thus it is also possible to save their lives. Next, if you don't have this cartridge, you can use high-dose corticosteroids for a cytokine storm. The next very important thing is that we noticed the difference between the L type of lung damage, respiratory failure, and the so-called H type in a timely manner. Before many developed countries in Europe and America. What's the matter? With L-type, airway patency is normal and hypoxemia, that is, oxygen starvation, occurs due to the fact that oxygen perfusion in the vessels worsens. This is the so-called L-type. And with H-type, on the contrary, the airway patency is poor due to pneumonia and oxygen simply does not reach the vessel walls. In principle, treatment is radically different. With L-type patients do not need to be intubated. It is worse, they need to be given oxygen through a mask, through the so-called CPAP. And with the H-type, on the contrary, it is imperative to intubate, otherwise oxygen will not reach the vessel wall through the CPAP. And many people abroad realize this a little belatedly. There was a publication of Canadian, Italian doctors who said that they intubated everyone at the beginning and the results were often poor. Deplorable. Only later did they distinguish between these two types of insufficiency. Now everyone abroad has learned this, and some patients are intubated and the other part is not intubated. These principles of treatment, these approaches, some innovative approaches were not immediately developed by doctors. This is an acquisition of experience, including for us. Plasma transfusion containing antibodies was successfully used in the treatment of COVID-19 in Georgia. How do you evaluate this method in general? In Georgia, one of the first in the world began to use the so-called convalescent plasma for treatment. That is, plasma transfusion from persons, from donors who have suffered this disease and recovered. Accumulation of protective antibodies is observed in the blood of persons who have undergone this disease. That is, they become immune. Their plasma for a while, at least for several months, while no one knows how long they persist. Whether they persist for life or only for 3 months or only 6 months. We took plasma from these patients who had been infected for 3 months, and this plasma prepared using a special technology was transfused to critically ill patients. Because we did not have a lot of these plasmas, because not all donors are suitable for this goal. They must first contain these antibodies in a high titer. Their blood must be suitable for transfusion. This person should not suffer from any chronic diseases or other infections. They should express a desire. Not everyone expresses a desire, so this plasma is in short supply all over the world. Therefore, this is not a method of mass treatment. This plasma is used only for the treatment of severe patients, where the usual standard methods of treatment did not work. The fact is that when you identify antibodies, you don't know whether all of these antibodies belong to the class of protective, neutralizing antibodies or not. To identify protective antibodies, and neutralizing is possible only in a few institutions in the world. In other centers, including our center, it is determined by the easy titer and assumed that if there are antibodies in high titers, it is likely there will be a protective antibody. Safe, absolutely safe. This is a normal plasma transfusion. If it contains protective antibodies in a high titer, the patient will be cured. If it is not contained, nothing bad will happen. Yes. That is, it will either be very useful for the patient, or in any case, there will be no harm. After COVID-19, rehabilitation is needed. Please give us advice, information and professional opinion on how to recover and what the medical profession says about rehabilitation and the post-infection period after recovery. In mild cases, we do not use any special rehabilitation measures. And in severe cases, we need to conduct certain rehabilitation for this purpose. A multidisciplinary group of doctors is important, which includes a physiotherapist and rehabilitation specialists. If the disease is mainly focused on the lungs, then this rehabilitation includes special breathing exercises, either without devices or with a special device. This is very important. It helps to restore normal lung function and sometimes reduce the number of fibrotic complications and the like. When it comes to the central nervous system, the cognitive system, if it was affected, this is especially often observed in aged patients who have been intubated and under sedation for a long time, that is, they have been given special sedatives for a long time and have been intubated. Then you need to carry out neurorehabilitation, various exercises, but already special, so to speak. Mental exercises aimed at restoring memory, restoring normal sleep, this is very important, restoring normal sleep. Tengiz Nikolayevich, thank you very much for such an informative conversation. In your person, I want to thank all the doctors in Georgia who stood at the forefront of the fight against the coronavirus. Thank you very much. This was a very useful interview. All the best to you and of course health. It's Experts Talk program and I, Serik Arkishev. Bye.